Welcome to Get Moving TV. I'm Dr. Chris Landon. I serve as your host. As we try and frame the healthcare debate, we've come up with these death panels. And Dr. Hornstein has been very helpful for us through the years through running different ethics committees while we really try and consider a person's quality of life and what the outcome is going to be. We've tried to frame this as a dispassionate piece of pink paper where people pre-make decisions about how much life-sustaining treatment they need. But there's another side to the glass, and that's the impact on the physician as well as the family. And Dr. Hornstein and I are going to talk a little bit about our experience, both with our own feelings and experience and how we can help a family through this, and also what we've seen back coming back from the family in terms of their own comfort with this kind of decision making. Dr. Hornstein, welcome back to Get Moving TV.
Chris, thanks for having me.
So I kind of opened it up a little bit. Just remind us about the physician-ordered life-sustaining treatment. I know we have a pink form, and we've talked a little bit about really trying to inform people about what physician-ordered life-sustaining treatment. So if we could just start there, and then we'll move it on to these death panels and that don't really exist. I know you've read the legislation and the ethical impacts and decision making that goes for us as a society. So if we could just review a little bit, what are the different parts of physician-ordered life-sustaining treatment? In terms of the check boxes, they feel like death panel check boxes here. What we have is 1, attempt resuscitation, CPR, 2, do not attempt, and then also the whole concept of medical interventions in terms of comfort measures. There's that whole Schiavo question that we keep coming up with, limited additional interventions, and then really full treatment. And on another show, we'd been talking to the mother of 2 boys with muscular dystrophy, and that their doctors wanted to maybe do too much, that we have other kinds of ways to support their lungs and their life. And then the whole question of artificially administered nutrition. The American Academy of Pediatrics came out with a statement just this month saying that yes, there are times when withdrawing nutrition is acceptable in terms of some patients, and yet here as a parent, feeding is really how we interact with children, and it has its own emotional impact. And then who signs it? Whether this is some director of nursing in a home with 30 or 40 or 100 nursing home patients, and does she just flip through charts and check off boxes, and then when the medical director comes in and signs off 100 charts, is that really what that conversation is all about? So I think that should keep us going for a while.
Well, thanks, Chris. I caught about 5 questions in there, so I'd like to get to all of them. They were excellent. But let me just start maybe for the audience at the beginning. The POLST form which you were holding up is the most recent option in trying to clarify patients' end-of-life care wishes. But it really is part of an evolution that's been going on for about 30 years in our country. The idea of advanced care planning, of saying, look, I'm sick, I have an illness, and I'm contemplating maybe dying. This one I may not recover from. So the question occurs, are there things I should be thinking about in coordinating my end-of-life care? While all of us, myself included, every patient that I've ever met wants to get better and wants to get healed. And you go to the doctor, you go to the hospital, and the expectation is, I'm going to get better. And that's certainly my wish that everybody does, both for myself, my family, and my patients. Unfortunately, as we both know, that doesn't occur all the time. And part of being human is dealing with the reality of death and dealing with the reality of dying. And there are times when, despite our best efforts, patients will die and patients will get sick and transition from being healthy to less healthy to dying and finally to pass away. The question is, do people have any control over that transition, and should they have control? And that's been a discussion that we've been having in our society for really decades, for 10 and 20 and 30 years. And going back to the case of Karen Quinlan, which you may recall was a young woman in a car accident and actually had an overdose in New Jersey, never woke up, and her family wanted to withdraw her from life support. And at that time in 1976, the court said they couldn't, because withdrawing simple life support meant killing the patient. And they actually had to go to court. It went up to the New Jersey Supreme Court, and the New Jersey Supreme Court said no, that patients and their families have the right to remove care that they don't want or is no longer working. And from there, from 1976, we then were struggling with do not resuscitate orders on patients where resuscitation wouldn't work. So on patients where we can revive their heart or their lungs because their illness can reverse, then we ought to. But there are those patients who we can't, where cardiopulmonary resuscitation, CPR, or in the movies a code blue, won't work. And in fact is a fairly violent procedure. And in fact, when it won't work and will hurt patients either by breaking ribs or sticking a tube in their mouth or prolonging their dying, patients felt they don't want that and should be able to turn to the doctors and the hospitals and say, look, kid, we know we're going to die and we would prefer to die without this kind of violent end. And so in the 80s, there was a movement to allow patients to reject certain types of treatment like CPR and do not resuscitate orders started to come into our hospitals. At the end of the 80s and in the early 90s, another tragic case of a young woman who got in a car accident, Nancy Cruzan, occurred. This case, this woman never woke up, and her family tried to remove her after several years from the ventilator and life support. That case was the only case that went to the Supreme Court of the United States. And in 1990, the Supreme Court made the determination, which is now law for all of us, that patients have the right to accept or refuse any treatments that we offered, including CPR, including ventilators, including nutrition or hydration, including anything. That patients' rights and the patient deciding what's best for them is really paramount. And that's really what we should listen to. So over the last, I would say 18 years, we have tried through a number of ways to get patients to exercise that right, to say what is it they don't want as they think about their end-of-life choices. We call those advance directives. In 1991, the US government, in the Patient Self-Determination Act, based on that Cruzan case, made a law, which is federal law throughout all 50 United States, that says any patient that enters any hospital facility that gets any Medicaid or any Medi-Cal or any Medicare funds must be offered an opportunity to fill out these advance directives. And in those advance directives, they do two things. Number one, it gives sort of a living will that says, if this were to happen to me, I don't want this. Or if this does happen, I do want this. It doesn't say it doesn't presuppose only not getting things. One can also say, no, I believe, according to my own values or my own religion, that I do want these kinds of treatments. Since 1991, that's been available to every American over the age of 18. But the second part of advance directives is also the part called a power of attorney for health care. And that's a crucial part, and it says this. A patient gets to decide, if I can't speak for myself, I get to pick somebody who will speak on my behalf. And their words have the same authority as mine do. And so you get to write that in these forms. Those forms are available at every hospital in our county and, in fact, in the United States. They're even available in doctors' offices, in health clinics. Certainly your attorney can help you fill that out. But that's available for everyone.